Well, welcome everybody. Thank you so much for coming today to this morning's Government Analytics Breakfast Forum. I'm Jennifer Bachner. I direct the Government Analytics program here at Johns Hopkins, and we've been hosting this forum along with REI Systems for quite a while now, about 4 to 5 years. And the intention was to build a community of people from the public sector and private sector and in academia to discuss how the public sector is using analytics to address important challenges. And we've really tried to create a forum that encourages a lot of discussion and debate and questions, so I certainly hope we do that today. We also have people who are watching via the live stream, so welcome to you as well, and you are very much encouraged to ask questions. You can also tweet about our Government Analytics Breakfast Forum using the hashtag GAB forum. If you are having trouble connecting to the internet, there are some instructions on this pillar here, because I know sometimes it can be a bit of a dead zone in this room. The way that the forum will work is that our panelists
techniques to use, how to get people to pay attention to the analysis that's been done and actually take some action based upon it. How do you know, what is it a senior executive or political appointee is looking for in analytics? We have these every 2 months, and we encourage you again to suggest topics for them and or to suggest people you'd like to hear from. Our panelists have each indicated that they're happy to take your questions throughout the discussion. In a turnabout on a lot of discussion forums, they may ask you questions. They may ask each other questions, and if you all are really shy, I may ask some questions too. So we'll try and keep it lively and hopefully interesting. Just a very brief bit about background about my company, REI Systems. We're very proud because one of our clients this past year, the Health Resources and Services Administration, won the first prize across all of government agencies, more than 100 nominees, for igniting innovation, and it was for a data analytics platform, helping them support their grantee health clinics, serving people with disadvantages and challenges getting access to public health across the country. And so that's something where it's been very interesting to me because there have been other government agencies, including just recently the U.S. Agency for International Development, that said, we really like that platform and that analytics capability, we'd like to take advantage of it. And what that demonstrates for me is something I think is a good lesson for you as well, which is many analytic techniques and capabilities are portable across government agencies. The reason we came up with the idea for this opioid problem on using analytics to combat the opioid crisis is a hope to think about, can we find and perhaps predict the next crisis? How are some different ways that are perhaps in use now, and some have been successful, perhaps others have not, in using analytics to combat a significant public sector problem? So we brought together what we thought would be a group of folks who can offer different sorts of perspectives on this. And bluntly, Mona Siddiqui, as the Chief Data Officer for the Health and Human Services Department, can do a great job of setting context and telling us kind of what is the situation, what are the types of analytics that are available, how is data sharing possible across agencies and components of government. Allison Olschlager, who is the Chief Data Officer for the Centers for Medicare and Medicaid, frankly, has lots of the core data about where are opioids being used, who is producing them, what sorts of individual physicians are making what sorts of behaviors, prescribing behaviors, and so forth. And last, we've invited Jim Liu, a professor actually in the business school here at Johns Hopkins, who works with artificial intelligence and predictive models, to be able to talk a little bit about, well, what could be possible? What's kind of some of the cutting edge of research in terms of thinking about perhaps not just the opioid crisis, but what other crisis next might we be able to identify? Where might it hit geographically? Who might it impact and how? And thinking about those things together, again, we hope will contribute to ideas about how can we next make progress in combating an important public problem in this country, opioids. Let me just give a very brief bit of additional information. Dr. Mona Siddiqui is a medical doctor who actually has her degree from Johns Hopkins University. So we're happy to have her at the campus here in the Washington, D.C. area. And she previously actually was part of the social and behavioral health group at the White House in the previous administration, the nudge group. So thinking about kind of behaviors in some cases within government and of course across America as well. Allison Olschlager has a degree from Georgetown University and was a healthcare consultant before joining the government, and her career has just shot up like a rocket. So she may look young, that's because she is young, and she has earned this honor very quickly and very brightly, and I'm sure that we'll all appreciate hearing some of the things she's been sharing with her CMS colleagues. And Jim Liu is a professor, a finance professor actually, who has done quite a bit of work in kind of things around Wall Street use of analytics and rocket science. Although he's not a rocket science, his degree is actually in finance. Some of those pieces of artificial intelligence, blockchain, and kind of predictive analytics will be very interesting, I think, when offered as a resource to government and to other sectors in addition to finance. So with that aside, we're going to ask each panelist to kind of give a kind of an overview of what they're doing, what some of their thoughts are. Again, I will invite you to ask questions. I will invite you to ask questions of each other. But let me now turn it over to you, Dr. Siddiqui. Thank you so much all for joining us.
Great, thank you, and good morning. It's great to be here. I thought I would just start by giving a little bit of history for the work that preceded what we're currently doing, just to put some things in context. In the last administration, there was a significant emphasis, as some of you may be aware, on open government and data as a mechanism for enabling open government. And as part of that, I think the department really led the way in releasing data sets for public use, both for researchers and entrepreneurs, initially through data.gov and now through healthdata.gov, which lives in the office of the CTO at HHS. Over time, we've released about 2,000 data sets. And it was interesting during the transition having a conversation around, well, this is great. We are promoting this as a resource for people on the outside. How is the department using its own data internally? And while we were having that conversation, we were also looking at, as a department, responding to an OMB memo around how does the department become more effective and efficient. And as part of our response to that OMB memo, we convened work groups for about 3 weeks on a range of topics. And those were from science policy, R&D, and other places. And the interesting thing I found was those work groups were comprised of leadership at HHS as well as frontline staff. And across all of the work groups, the number one thing that emerged was the use of data and the lack of the use of data at HHS. We heard things like HHS is data rich and information poor. And that tells me that over the course of the last many, many years, there has been a culture shift that's happened at HHS where more people are talking about the use of data. People who are not necessarily embedded in that space every day, but who understand that there's more value that could be created from better use of HHS's data. And so given the work that we've been doing within the open data side for external use, and now sort of this, I think, more collective understanding of the lack of using our own data internally, what I'm actually tasked with in my role at HHS is new as the Chief Data Officer for the department, is to create an enterprise-wide data governance structure for the department, and to also enable better data sharing to occur across all of the agencies. No easy task. And so as part of that, we, I'll tell you a little bit, we first said, we need to understand, we think we have an understanding of some of the barriers, but we don't really know from a granular level. We hosted an opioid codeathon. Did you guys, anybody hear about it? The opioid codeathon at HHS? Yeah, okay, great. I see some nods. And this was last December. We opened HHS to about 250 coders. Anybody been to HHS? Okay, great. So you know the Great Hall when you enter, that was taken over by coders for about 36 hours. And the HHS security, they were not a fan of me. And we brought together about 70 different data sets from across HHS and from other federal departments, including Department of Transportation that has 911 data, Department of Justice that has drug seizure data for opioids, from Census, Department of Education. We had about 7 states that brought data. Unfortunately, it wasn't as granular as we would have liked, as you can imagine, but it did present an opportunity to do a couple of things. First, it was my team's sprint to understanding what some of the challenges are for data sharing, whether those were legal, technical, or frankly cultural in many cases. It was also a great opportunity to showcase to leadership what can happen when HHS data is put as the mechanism to help address one of the biggest problems that is facing our country today. And data can be a very esoteric conversation, right? I think a lot of people will nod their heads and say, yes, we understand the value of it. But again, unless you're embedded in this space, you don't really understand what it is that we're talking about and why there's value from it. And so we hosted this, and we had about 3 challenges that we put forward around the topic areas of prevention, understanding treatment, and understanding usage. And it was fantastic because one of the reasons I wanted it to have it in the Great Hall was to have people come by and see what was happening, to have HHS staff be able to come and have conversations to see how data was getting used. But more even than that happened, which was that our acting secretary just dropped by more than a few times because he was fascinated by what was happening. And to sit down with the team and to see how data sets that usually are not used for this purpose could be used to come up with solutions and a framework and how to think about a problem that's different than the things that he's ordinarily hearing every day. That was sort of culture change happening right in front of me, and it was more than what I could have asked for. So we had solutions develop around showing families where take-back programs are across the country. We also had a solution that was real-time to providers to see how their prescribing patterns were matching with other providers. And a ton of other solutions, honestly, it was very hard to pick, but those were 2 of the winners. Following that, what we wanted to do was to take a deeper dive into the data sharing status at HHS. And so the team fanned out to about 11 different agencies, including CMS, FDA, NIH, CDC, AHRQ, HRSA, SAMHSA, IHS, ACF, ACL, and I might be forgetting a couple. And we met with the leadership of those agencies to see what their priorities are moving forward from a data sharing perspective. And we also asked agencies to tell us what the high value data assets are. The reason being that HHS has thousands of data sets, and we could spend the next 10 years doing a landscape analysis of all data. And that's not what I wanted to do. I wanted to really have a conversation around what are the challenges when it comes to sharing data across agencies, not for external use. And so we asked the agencies to identify 3 to 4 high-value data assets, subjective, but part of it was what they felt were high value, and the second was data sets that are frequently requested by other agencies. And then we spent probably 2 hours doing a deep dive data asset review per data set. So all in all, it was about more than 100 hours of structured, semi-structured interviews across the department. And we then took that information back and released a report about a month ago, maybe a little less than a month ago, that was looking at the current state of data sharing at HHS. I think that really the first comprehensive look across the department, and we identified about 5 challenge areas that we see. And again, the purpose wasn't to call out a specific agency. I think HHS is not unique in these issues. I speak to colleagues across the federal government and across many other departments, and these are the same challenges that many of us face. Some of them may be different slightly because of the regulatory differences, but really essentially those issues are the same. And so I would urge you, if you haven't, I mean, I think it's a great report. I think it's a page turner, so I would take time to read it. It's about 16 pages. And gives you a sense of the state of the department. And we've also included in there, which I think was really important, quotes from staff that we were speaking to, because I think it really tells you sort of the, from their perspective, what it is that they're facing. And so just as an overview, we don't have standard processes for data sharing. Sometimes data use agreements can take a year. I was on the outside working with a White House team, and then before that, I'm a recovering academic because I used to be at Hopkins, and it would take a year to negotiate a data use agreement on the outside. It can take the same amount of time internally. Unacceptable. We don't have standard technical formats in which we share data. Sometimes when I've asked for data, I'm referred to a PDF. Again, not acceptable. Our agencies are not resourced appropriately, frankly. And we say a lot about what they should be doing, but at the same time, I think the resources speak to the priorities, and we're not resourced appropriately, either with often staff and expertise or financial resources to be able to really make data sharing a priority across agencies. We spent some time in the report providing an overview of the regulatory landscape, which I think if you're new to that space is worthwhile to have an understanding of as well. So that's sort of an overview. Our next phase right now that we're in the midst of is really developing what the future state for data sharing should look like at HHS. And for that, we've, again, gone to Allison's team and others, about 5 or 6 different agencies, a subset of the ones we originally spoke to help us define the solution. We'll put out a version of that report, hoping by the end of the month. And then we'll move rapidly into sort of an agile approach to figuring out for a platform what that should look like, as well as the governance and how that fits into the larger HHS organizational structure from the top down. Data management and looking at data as an asset, and that sort of governance needs to be really at the very top of the HHS leadership. And I think there's a commitment from the department to doing that. So that will be our next phase. We're also continuing to work with the teams who develop the solutions, and I'll just forecast this a little bit for you. Keep an eye out for a potential announcement in a month or a month and a half, where one of those teams that developed a solution is going to be scaling that solution in a pretty exciting way. So I'll just put that out there, and we hope to share that again as a demonstration of what can happen when data is used as a mechanism for public-private collaboration, which I really think is what should be happening more.
Well, I may ask, REI Systems developed performance.gov, and it has kind of the tip of the iceberg as public, and a lot more detailed data is available across government, some of it only to OMB and the agency that generated it, but some of it government-wide. Is there anything similar kind of for data where it's pretty easy, or would be pretty easy, for the government agencies to find out what data sets do others have that maybe is not public?
No, so data discoverability is a huge issue. Oftentimes and it makes sense, right? I don't want to say that, I don't want to give criticism here, but I think it makes sense when you are running programs and the data is really an outgrowth of the programs you're running. Of course, a lot of the programs are so different that you're running them in silos, and so the data develops in silos as a result. And unless you have, again, the resources, the bandwidth, the relationships over time with folks at the other agencies, data discoverability is a problem. And so you look at a platform kind of like what GSA has developed, and GSA's Dan Crowley over time over the last 4 years and they're smaller, of course, so it's, but they have developed over time a platform that does enable both the data discoverability as well as the governance and the sharing to happen. And there are states that are leading the work in this space as well, because states have to manage resources efficiently and effectively, and they're at the front lines of fighting the opioid epidemic and other issues, and managing resources through understanding their information and data is essential. So I'm looking to a lot of states that have led the way here as well.
One other question. A lot of what you've described is terrific, getting data sharing across government agencies, but it also makes me think, there may be some private sector data. Well, let's pretend pharmaceutical manufacturing and shipping rates.
Yeah.
Has HHS either tried or succeeded in getting access on a kind of an ongoing basis to data from significant private or nonprofit sources? So
we get data from, we contract for data. I mean, different parts of HHS, they do this. And some of those are prescribing data from vendors, and yeah, absolutely. So there are those types of partnerships. Part of what we hope to be able to also address are the inefficiencies in the way we acquire some of this data. So if FDA is getting the same data as CDC, as ASPE, we need to be, I think we should all have a commitment to having a more effective and efficient government that is using our dollars most efficiently. And being able to consolidate our purchase of data and software, those should all be things that we look at.
Well, as we know, opioid crisis, it is a big issue also among the homeless and hard-to-reach population. How do you acquire your information and evidence for the hard-to-reach population, namely homeless veterans?
I will say that that is not the only population that it's hard to acquire data on holistically, right? So you're right, absolutely. There are many gaps in information. If you even take an easier question like understanding the number of overdoses that are happening, we don't know the number of overdoses that are happening, partly because there are populations that we're missing. But we know the numbers because of the people who showed up to the emergency department or who get hospitalized because we have a claims record, right? But we don't know the people who get Narcan in the community who don't get captured in any database. And so trying to get a sense, I mean, the numbers that we have are clearly underestimating both mortality as well as overdoses. And you know, I think we have to really work with community partners at the local level to be able to try and get some trends for what it's looking like. We might never get the national absolute numbers, but if we can start to get more granular information, and by the way, more timely information, because oftentimes the information that HHS has lags behind at least a year. And if you talk about having data-driven action, which is really the ultimate purpose of what we're trying to do, having information that's a year old or a year and a half or 2 years old when we're trying to make decisions around how money is allocated, those are things that eventually need to change, and they will change over time. We want to create the foundation for that to start to happen. But absolutely, you're right, there are many populations that we're completely missing.
Well, of course, mortality data and overdose data, it is a tip of the iceberg, especially for the hard-to-reach population. What we are concerned as epidemiologists and as a firm that we are trying to support this situation, it is the use of math among the hard-to-reach population. And when we think about math, it gets a little bit complicated, because when you really think about it, as one of my colleagues always say, there is no at the math for the hard-to-reach population, because when it comes to the assistance treatment, it is really critical on how we are going to use math for the hard-to-reach population, especially our homeless veteran. And that is one of the areas that we are hoping that we can use artificial intelligence to forecast based on the available variables to see whether we can provide some sort of information and evidence in that respect. Is that something that you're thinking about?
I think that for a lot of these, we have to partner with others, right? Because we don't have access to the data. So it would be great to be able to, and again, it's not just on the treatment side. I think we focus, and I'll put my physician hat on, I do think we focus a lot on the treatment side appropriately, but I would also love to focus more on the prevention side. And how do you identify those at risk, and how do you prevent people from going down that path? In the course of having worked in this space, and again, I'm a physician, but I'm not a pain management specialist, and running the Codathon, I realized just how many people, I mean, we talk about the numbers, but there's so many people who are impacted by this. And so many families. I mean, I would have phone calls with people who would want to work on this project because their son was suffering, or they had a loved one who had died. And the scale and scope of this is just enormous. And I think we also need to think about the thing, sort of how do you help people from even starting down that path.
Thank you.
Yes, Dr. Siddiqui, opioids were something that we didn't realize was going to be a crisis 15 years ago, maybe 20. are there people thinking, and or where might they sit, what kind of data are they using to think about, well, what's the next crisis, and how can we notice it early and perhaps then intervene to forestall it?
Yeah, that's a great question. And I've been asked this before, is the federal government prepared to understand the next? And my frank answer is no. I think a lot of the data that we collect because we're running particular programs. It's not because we've sat down and thought about, I do think, CDC and CHS, they collect a lot of great information on the health of the country. Are we in a place where we are collecting data that can help us predict the next thing? I don't know. I don't think so.
Is the report on data sharing located on your website?
It is, yeah.
Yeah.
I'm actually a pain physician, and one of the problems we have is that the only access that we have to data are the prescription monitoring programs in different states. Yeah. They're very ineffective and inefficient most of the time. There's a lot of lag time. For instance, if I see a patient tomorrow and I check their PMP from, I have to do Washington, D.C., Maryland, West Virginia, Pennsylvania, all the surrounding states, each one has a different login and password. If I check a patient today for tomorrow, I see the patient, the PMP is clear, and then when they come next time, I realize that, 20 days ago, the first visit, they were given an opiate from someone else. So there's a lot of lag time. Is there anything that HHS is doing to effectively, alter the PMP so that it's more efficient?
Yeah, so there are a lot of efforts, I think, happening both at the state level as well as a fair amount of attention for this on the Hill. I would continue to monitor those. I think so much of the ways in which PDMP operate are dependent on state laws. So that's been a very tough conversation.
So that's what, I've just been frustrated. I've been doing this for 10 years, 11 years in my pain fellowship at Cleveland Clinic, and there was a lot of talk about this, but nothing has changed. Yeah. So my business partner, he's in Boston, but he actually graduated from Johns Hopkins with this specialty, and we formed a company to try to help with, national PMP, and we're stuck because there's so many regulations per state, and I really want to eventually see a more efficient PMP with real time, and that's what we're working for. But we're stuck. We have this great company that we formed. We spent a lot of money starting the startup, but we're stuck when it comes to those levels. Is HHS doing anything to help with that, or what can we do to talk to HHS? Because that's really, as a physician, the only data that we have access to are the prescription monitoring programs. And if a pharmacist enters the wrong middle name, for instance, I have patients who are clear on the prescription monitoring system. I have no idea, but then we have to call the pharmacist, and yes, they did fill, but then we realize they misspelled the name. So, we have to make it more efficient.
Yeah. No, I absolutely.
And it's not just opiates. We need to regulate benzodiazepines.
Yeah.
Different like Adderall, Ritalin, different stimulants. Any controlled substance needs to be monitored more effectively. So
agreed. Absolutely.
That's where our frustration
is.
Just quickly building on that, so CMS has also been thinking about PDMPs, but the other thing that we've been talking about is interoperability, right? And how can we share data from the electronic health records between physicians, between, from payers to patients. So CMS has a program called Blue Button that allows patients to get access to their claims, their Medicare claims data in an API that enables them to have it on their phone, share it with their, if you're a Medicare beneficiary, share it with your son or daughter, share it with your doctor, but also starting to think about how do we encourage that data sharing between physicians.
And that's exactly what we're doing, to try to get an application where physicians, patients, everyone can see exactly in real time. And then a physician or pharmacist can be alerted right away instead of this lag time where you realize 1 month later and then the patient's dead from an overdose of benzos and opiates that they got from their psychiatrist and then went to California on vacation and feel that I have no access to that.
The state of Maryland has already started a program on real-time data collection on prescription of opioid and identifying the patients and looking into that patient record to see how many times they were prescribed opioid. And that is a very good thing. However, our company, which we are collaborating with McVet, and signals. We are more concerned about, as you mentioned, Dr. Asadiqi, first the prevention aspect of opioid addiction and the disease of opioid. Secondly, we cannot possibly have any real-time data on hard-to-reach population because they don't have the privilege to go to a doctor. They don't have addresses, they don't have insurance, they don't even have Medicaid. So they go to the homeless primary care clinic and they are given whatever they are given without any supervision. So when you are asking about what is our future crisis, I think if we control this crisis, our future crisis, if this is not controlled, is infectious diseases, HIV/AIDS, STD, cardiac arrest, infection of the heart, and all those things will be our future because it can spread in our population, which is also not hard to reach.
Thank you. I'm going to suggest we move on to Allison, and the reason is because I think actually Dr. Siddiqui will need to leave a little early at 9:45, and I'd like Dr. Siddiqui and Allison each to have, Ms. Olschlager to have a chance to hear and then ask questions of Jim Liu as well. So,
Sure.
Continue.
So, kind of building up what Mona was talking about, many of you know in June of this year we released our CMS opioid roadmap, and a lot of the topics we've been talking about so far are in our roadmap. So we identified 3 key pillars. The first was around prevention, so managing pain using safe and effective treatment options that rely less on prescription opioids. The second is treatment, so expanding access to treatment for opioid use disorder. And then the final pillar is data. And really when we think about the opioid crisis from CMS's perspective, we're thinking about the populations that we're dealing with. So 140 million Americans are enrolled in one of the 3 programs that we oversee, Medicare, Medicaid, and the health insurance exchanges. And when we think about data, right, we have really rich data on our Medicare population. We've been collecting it for a number of years, particularly those in the fee-for-service program. We have Part D information about their prescription drugs, but also starting to think about how we can expand and use our other data sources, whether that's the Medicare Advantage encounter data that we announced last year. We're starting to release to researchers, actually this year. I'm getting my years mixed up. In April, the administrator announced at Datapalooza that we're starting to use our Medicare Advantage encounter data and give that to researchers. Or it's the Medicaid data, TMSIS, transformed MSIS, and thinking about, we've been collecting that data from all the states and thinking about how we start using that and start getting that out to researchers and using it internally within HHS. So when we think about data, we think a lot about how we're sharing our data and getting it to external folks, whether it's other HHS agencies or the external research community or even generally to the public. So Mona talked a little bit about the Codathon. One of the things that we contributed to the Codathon was a lot of the data that we make publicly available on prescribing habits, opioid prescribing habits and other prescribing habits. So we have a data set that we have released for a number of years now that takes the Medicare prescription drug information and summarizes it at the prescriber level to say which prescriptions are each individual prescriber prescribing to Medicare beneficiaries. So you can take that data, and we actually do calculate the opioid prescribing rate. So for every physician that's prescribing opioids to Medicare beneficiaries, we publish their opioid prescribing rate. And then we've taken that data and put it into a mapping tool. So on our website, you can go into our mapping tool and see, when you open it up, it's at the state level, and you can see variation across states in terms of opioid prescribing, but you can drill all the way down. So as you drill into the map, it goes down to the county level and then the zip code level. And again, behind that map is the individual prescriber data. And so it's really exciting to see what happens when you take that data and start combining it with other publicly available data. Somebody came in just this week and showed us a dashboard that they've developed where they take our prescribing data, some mortality data that CDC publishes, and start putting that together in a format where you can go to state officials or local officials and say, here are the trends that we're seeing in your area across all of these different HHS data sets. So it's really exciting to see how all this data can come together to help people, as Mona said, make better decisions, right? Because that's ultimately the goal of getting all this data out there, and having the data internally is helping us drive towards better decisions to address this crisis. Yeah.
So when you look at those decisions and you see them, like I prescribe over 400 opiate prescriptions a week, but when you see my map, it's going to be high. Does that alert you, or do you say, okay, there's pain management? I just don't understand how you evaluate that data and what do you do with that data?
I think you can start by saying, you know, what are the high outliers? So maybe we look across all the pain management doctors and say, you know, we know your specialty, we know you're a pain management doctor, you're probably going to be prescribing opioids, but across your entire population, are you prescribing opioids at a rate of 50% compared to, you know, other doctors, or are you in the top percentile of pain management doctors, which may be appropriate, right? We're not saying that the data shows whether the prescribing is appropriate or inappropriate. It's just a place to start when you're thinking about addressing these issues.
I have a basic contextual question.
Yeah.
This might be best answered by Mona, but you might. Are there alternative pain medications besides that are non-opiate and not addictive? And if not, what is there any government leadership on? Because obviously a lot of people are in pain, and we don't want them to be. So maybe you could give some insight into, sort of generally speaking, are there alternatives, or sort of what is the context here? Yeah.
Jim, did you want to, or should I go ahead?
Well, I'll try to address this question. All right, and so my background, I've been in here at Johns Hopkins for 6 years, and I've taught business classes to doctors and students, and you know, prior to Johns Hopkins, I worked on Wall Street, so I created sort of quantitative trading models, so lots of data, and we try to make predictive models and so forth. And then right now, I have a consulting company that is called SoCat, named after my two daughters, Sophie and Catherine. They're like 9 and 12. And we do machine learning, AI, and blockchains, okay? And so why am I sitting here on this opioid panel discussion is because actually one of the students in one of my, I teach a big data machine learning class at Johns Hopkins. He was a doctor. He's a doctor at Hopkins. Also, he worked at McKinsey Consulting. He quit his company to join a startup. And I thought he was crazy. I said, why are you going to do that? I mean, you have this wonderful career, you know, at Hopkins or McKinsey. This is a top consulting firm. And why would you go and join this startup? He said, you know, no, Professor Lee, you got to see there's a big problem. It's called the opioid crisis. It's happening right now. So, of course, I'm a curious person. You know, I grew up in Oklahoma, and, you know, I have friends who sort of, you know, have been affected by these drugs and so forth. So I started looking into it, and it's really, really fascinating because you have to sort of back up. How did we get here? We're trying to solve this crazy problem here with data and stuff like that, but let's back up for a second. How did we get here? So imagine I'm going to tell you a story, and hopefully the story will get you all fired up, because this is kind of what happened. In 1990, you know, there was this wonderfully gifted sort of person, not only a doctor, but also very good at marketing and advertising. And so this person sort of realized that doctors are a little bit naive when it comes to business. And when they read the academic journals, sometimes there's advertisements inside those academic journals. And so, you know, this guy was a brilliant advertiser. So he like literally put in that these things were okay, and you should prescribe more of these things into these journals. So then doctors are so busy, they rifle through these journals, they don't read all the articles, maybe they read some abstracts, and then they just sort of remember, oh, you know, this particular painkiller is going to be fine. And so what happened was we had this you know, prescribing of these pills that people thought were safe, reasonably safe, and the doctors thought that they were doing a good job, you know, helping the patient with their pain. But behind the scenes, this organization was funding research and sort of saying, you know, funding the research. When you're a corporation and you're funding research, of course, what are you going to do? You're going to fund the research that helps build your business, right? And so, you know, this caused this really bad snowball effect. And what happened is there was too many prescriptions, and, you know, the regulators sort of, you know, everyone's to blame. I mean, you know, the doctors are to blame, the regulators are supposed to blame, we're to blame, right? because we weren't vigilant enough on watching this thing sort of grow out of proportions. You know, now we fast forward today, you know, how much does it cost us per year? You know, that goes way over $50 billion. How many deaths is it per day? At least 100 or more, right? We're like literally out of control. But what we have to do is we have to back up and we have to go look at these organizations. How do we get here? You know, let's educate our doctors that these things are really bad. these things are very addictive. Now it's not, you know, there's like 10 people in a room, 9 of them will take it, nothing will happen. But the one that takes it will become addicted and they can't get off of it, right? But we don't know who that is, right? So, you know, it's a problem, I think, that is very emotional, right? I mean, if you have, has anyone had anyone affected by the opioid, right? When that happens, I mean, that is an emotional response. And, you know, I mean, I've had friends who've been through very difficult, you know, situations because of these things. And so, you know, I feel as an academic, I can sit in the ivory tower, I can say whatever I want to say, I'm okay, right? But this is a problem. And the way that we fix it is that we open up the transparency and let everyone see what's going on, right? And let's be very objective of, you know, what are these corporations that are creating these pills? How did we get here? How are they marketing these things? How do doctors misinterpret sort of these research academic reports, right? And then, you know, educate people, you know. I absolutely agree that data is going to help us, right? Absolutely. I think data is in silos. If we can pull the data out of silos and we can create AI and machine learning models all day long, absolutely we can do amazing things with that. But, you know, just because we're analyzing data, right, and we're you know, publishing on the website, I think what you're doing is wonderful because, you know, shaming people and doctors, you know, prescription per capita is probably the right thing to do. This is a top 10 list. The doctors are going to start, you know, seeing that and they won't like that, so they'll start adjusting the way they behave. They should. I think that's a great approach. I have to say something about HHS because HHS has some amazing people in there. I mean, like Jose and Oki and, you know, Mona. This is like better than Silicon Valley in terms of applying emerging technologies to problems in the government. So I applaud them completely. I think the DC scene when it comes to AI and machine learning, because of so much data, we could actually go in front of Silicon Valley. So once we figure out how to put the data and sort the data problem, it's a big problem, absolutely. You know, when we put machine learning and AI on top of that, it's going to be amazing. So the potential is all here. Yes?
Yes, you're absolutely right that the issue is emotional, but also it has economic aspect. In 2016, there were 150 million prescription was written for opioid, and the profit to pharmaceutical was 11 billion. So another point that you raised, this is absolutely wonderful, and I totally agree with it, that this data that you are collecting, it is so essential, mainly for training our primary healthcare physician, so that they should understand when to prescribe opioid and what kind of opioid. Maybe we should completely eliminate opioid, only to be used for the end-stage patient that you're suffering from pain.
No.
Okay,
There's a
so
differing opinion up here.
Yeah, no.
Wait, so let me finish because I want to stay a little bit on topic to this discussion. Imagine a world where you can have access to any data set that you want across the government, and somehow it's all merged correctly. Okay, and that's a huge step. Okay, we're not there yet, and we'll probably in my lifetime never be there. But just imagine that you could get any data from the government that you wanted, right? And so now, in one particular data set, it says, okay, this person has been diagnosed as being addicted to opioids, right? And now you have all the other data sets, including the genome sequence and everything characteristics about the patients and their history and all this other stuff, right? And whether the drugs are taken in their history. Could you create an AI model to make predictions on people if they could get addicted to opioids? Absolutely. Absolutely. No problem. No problem whatsoever. Will you hit a 95% accuracy, 99% accuracy? Probably, I would guess. In my best, you could do it. You machine learning and AI, you could do it. All right. So, you know, building a predictive model is possible. You know, data's in silos is the difficult challenge. Okay. What are you going to do with that predictive model then? Then the other thing is, so anyone comes in and the doctor's now going to prescribe, and there's an app. You put in all the information. You hit 99% chance that you're going to be addicted. Okay, I'm not going to give you opioids. I'm going to give you something else, right? That is all in the possible realm of the technology that we have and the data that we have today. So why can't we do that? That's the question. Why can't we do it? Why do you think we can't do that? The technology is there. We could build these models, okay? But why can't we do that? What do you think?
I'm Gerald Roberts. I'm a registered nurse and an evaluation scientist with LMI. I started out my nursing career as an hospice nurse, helping people in the high-rises in Baltimore City, the low-income high-rises, to die with dignity. I also was the victim of a severe accident that put me into shock trauma for over a week. And I also lost my nephew to an opioid overdose. So I have 3 different perspectives on opioids. Getting rid of opioids is ridiculous. It can't happen. People actually need opioids, especially in cancer, especially in severe trauma. What they also need are physicians who are willing to say, you've had enough, you have met the guidelines, there are ways to transition you off. When I was discharged from shock trauma, I was given 30 milligrams of MS Contin, 90 tablets, 2 refills. Now, how ridiculous is that, okay? I'm a 200-pound man who had a severe traumatic injury to my leg, but God, really? But on top of that, there are some issues that we face here, particularly in this area. I live in Washington, D.C. I work in Virginia. My physician is in Maryland, okay? That's 3 different PDMPs. Plus, I'm a veteran. I don't have veteran privileges, but I could. If I did, that's 4 PDMPs that a physician has to address. The average primary care provider has between 12 and 15 minutes to see a patient. It takes about 2 to 3 minutes to access each PDMP and another 2 minutes to access the EHR from scratch, because you have to log out of that to get to the PDMPs. Multiply that out, there's 12 minutes. When am I being seen? Okay? You have somebody that's from the back office doing that work for you, that's fine. Is that information that's being drawn together relevant to the physician at the point of care? So this goes back to, I did my first master's thesis on why HIPAA would fail. And it hit 7 of the 12 points of my thesis, many of them overcome by the Joint Commission. But we are in a position today where we were in 1995 with information security, with the opioid crisis. We have every single state in 1994, 1995 had their own version of what became HIPAA. Under the Clinton administration, they federalized a floor and they said, for information security, you have to be at least here. You can go anywhere else you want, you gotta be at least here. And when they did that, it made it possible for the state laws to remain. So the states maintain their sovereignty. They could either hit that floor or go above it. Maryland went much above it. But this is an opportunity now where the federal government can say, hey, wait a minute, we did this for HIPAA and it kind of worked. Now, not 100%, but with some help, it worked. This is an opportunity to build that kind of a capability and to start encouraging physicians to use a system that actually works at a minimum, that allows interoperability across states, by just pointing to them and saying, your system has to meet at least this criterion. And that's something CMS, ONC, HHS generally can give a great deal of guidance to the legislature around.
Absolutely, but also HIPAA was written in a particular time where we didn't have this technology of AI and machine learning, right? And so, we're protecting data for patients, which is great, right? But to what extent, right? If HIPAA, the people who wrote HIPAA and passed it knew how powerful AI could, be with data, would they still want that? I mean, because I think the public
HIPAA for data privacy. I'm talking about comparing HIPAA to what we're doing right. Forget the data privacy issue.
Yes.
What HIPAA did was set a floor. If you look at it exclusive of data privacy and security,
yes,
ignoring HIPAA as a data privacy and security framework and looking at it as a legislative framework upon which to build a floor and then whatever ceiling you want, you can apply that to the PDMPs, ignoring data privacy, and still say you have a floor for the PDMP. It has to be interoperable across all states and has to be useful and available to a physician at the point of care within 1 minute, and then build from there.
First, I want to applaud Allison, because I have 2 daughters and I'm trying to get them into machine learning, and they're like, there's too many guys there. We want to see a bunch of guys, so anytime there's a woman who's doing data science, I'm like,
Yes.
So, thank you. But, just to summarize some of, my thoughts, I think we're in a difficult situation. The problems that you mentioned, it's not a technology problem. This is a coordination of human beings problem.
Exactly.
The technology could absolutely solve it. And if you mandate that we do this, right, and then we get the buy-in from the government and the Congress and so on, the actually building that technology and building interoperability of these systems is actually, it's going to be, much shorter in terms of time, on the order of months probably, right? But convincing people that we have to do this, we're in DC. How long does it take to convince all those parties, right? I mean, a lot, right? A lot of effort. So the solution using technology, big data, machine learning, AI, that's the easy part. The hard part is the human beings convincing everyone, let's go move in this direction, right?
So Jim, on your behalf, let me ask kind of Allison and Mona. Jim has kind of hypothesized, well, we can figure out which small part of the population is likely to become addicted if we can compare genetic profiles to prescription or receiving of opioids. And presumably, you're the largest payer for opioids in the country. And Allison and Mona, you help kind of decide what the policy is. What policy changes might be needed to allow the data to be shared to reach a resolution such as Jim suggests?
Yeah, so I mean, CMS actually already does a ton of data sharing, whether it's across HHS or also with external researchers. And just building on the question that you were asking about treatment alternatives, one of the things that we've been thinking about is how we work with the National Institutes for Health, right, who are doing great research into options for alternative treatments, and how are we sharing the Medicare claims or Medicaid data when it's ready with them to enable them to do the types of research, whether it's running clinical trials or it's more health services, historical types of research. But then also, how is NIH doing that evidence generation and sharing that information back with CMS to help us make coverage decisions about alternative treatments? So does acupuncture work for low back pain in, the Medicare population, which are a different population than those in Medicaid? And there's maybe not as much research in that space, but for us to make a coverage decision to pay for something, we need that evidence. We don't just say, oh, we'll try anything. We want the evidence to make sure that we're paying for something that's going to work. And so it's really important to us to make all of our data available both across HHS, so to NIH, we have CDC using our data, ASPE uses our data, but also externally to academic researchers, nonprofits, even for-profit companies who come into our virtual research data center, which is an environment where you log into our database, you're working within our environment, but you can get access to the record level claims data or prescription drug data, and you can bring your own data in and do linkages to compare, what are we seeing if I have data on genomic information and I want to link that to the claims and understand what that's, how I see the results or do AI type things. We enable all of that.
So I'm regretting now that we didn't invite CDC, because one of the things they do that I love is they take completely external data. Google searches for flu symptoms. You could take something similar. Google searches for OxyContin. And so I'm curious as to whether or not, again, anyone in government now is trying to grab data from an outside source to get something that's closer to real time instead of kind of a year out of date, and then taking that to try and kind of intervene.
Yes. So we are looking at both data that is more real time from other sources outside of HHS, and also data that is potentially accessible directly from states. So, oftentimes the data sets that we have, we need to wait until all of the states have reported to a particular agency before those are finalized and shareable internal to HHS. And again, that is the thing that creates a 1.5-year lag often. Can we go directly to states to try and see whether we can do, again, not absolute national numbers, but a sample size that allows us to do some trend analysis of what's happening and where some emerging issues might be. That is something we're actively looking at. If our patient was complaining of pain and you didn't have an order written down, then you weren't doing your job. And that was because pain was the fifth vital sign that was promoted at that point. And I think, to your earlier question around can you predict sort of the next thing? Well, I think as a community we have to just question more, because at that point we weren't saying that, or it wasn't sort of commonly accepted that these were as addictive as we now know that they are. And there's culpability sort of across the chain. But as a community, I think we need to sort of stop and question before we adopt practices. I know when I saw an ad, which you all may have seen as well, again, this is my personal opinion, for opioid-induced constipation. Anyone seen this ad on TV?
Oh, yeah.
I just really lost my mind when I saw that. Because the fact is that we're, again, creating a diagnosis for a problem that we created. So in my mind, we are giving the medication that then creates a problem that then we can then create another medication for. And again, we just need to stop and then think about what it is that we're doing. And again, not every problem needs data.
But which organization in the government is supposed to regulate such things? FDA. Is that the FDA? So who in the FDA should be sort of protecting, us from this practice of just marketing like crazy to doctors, and just that the message is completely nonsense, right? And so whoever that person is, we should invite them here, and we should have a conversation at Johns Hopkins.
That's such a person exists. I am curious.
A couple questions.
Yeah.
Hi, Erin Breland from Agility. I am also a recovering academic, and I'm not as well read as I should be on this crisis and situation. But a thing that I keep hearing is naloxone distribution. And going to your, sort of treating a side effect, is that treating a side effect and not the actual issue? How are naloxone education and naloxone distribution programs, are those being tracked the same way or on top of opioid distribution? And it's sort of for the room, maybe not necessarily for you all.
Well, so I know that one of the ways that you can track the distribution is, so again, if it's a first responder, it doesn't make it into a regular database, but what you could do is track the tracking number on the dose that's given, and track the amount that's distributed. Again, that would be working with sort of state and local partners to be able to do that. And so is your question of, yeah, I mean, absolutely, we're looking at how much is being given as a measure of overdoses, but also stretching resources. Then, again, this is not my domain area of expertise, but I was reading an article that was talking about how police departments' budgets are getting strained because they have to devote a substantial amount of resources now to buying Narcan that they weren't doing before. And so just imagine those resources getting diverted from other places. So this is impacting, many programs, and probably impacting us in ways that we don't fully understand.
Just building on that, yeah. It's, one of the things that we've been thinking about is when someone is getting a high dose of opioids, should there be co-prescribing of naloxone? And as Mona said, sometimes it's hard to track that in our data because they're getting it for free from a clinic, or they have it and they got it before they were Medicare eligible, and it has a shelf life of 2 years, so maybe they haven't used it. So it's one of those things where I think there's a little bit of a hole in our data because there's such an effort to make this available. So we can't always tell, is the co-prescribing not happening because of a good reason, or is it not happening because we need better training of doctors?
So quick thing, along with my regular job, I'm also a professor, and I've got a doctoral student who's actually doing a qualitative study on multiple use Narcan recoveries, and she has 16 people who have been given Narcan by lay people. who have not gone into recovery programs, but keep overdosing and keep getting recovered by Narcan. It's a qualitative study that she's doing to try to figure out some of the themes that are around these people that feel like Narcan is now my savior, and I can keep overdosing knowing that my friends have access to Narcan and that I'll get recovered. The maximum was 5 recoveries for this one person, and she introduced me to a person that's had 3 recoveries and has no interest at all in going in for a recovery program because he's got it. He's going to get saved using Narcan.
Ms. Olsweiler, I'd like to ask again, kind of thinking in the longer term future beyond opioids, are there trigger warnings that can come from CMS data writ large and that perhaps could be driven by artificial intelligence, but that might be able to say, for this new medication, for disease X, all of a sudden we've had a 30% spike in prescriptions, or in this particular geography, people are prescribing this treatment or this medicine 5 times more than any other geography, or these 10% of prescribers are all of a sudden they've changed their behavior and they're much different than the rest. So my question is, in part, is there a conscious effort to look and set those triggers that the data could tell us, or some artificial intelligence that helps figure out, even where we aren't thinking about it and looking, what might have triggered that we didn't even know to look for, but that the artificial intelligence could tell us, hey, that trigger has been tripped. It's not, it's not opioids or pain this time. It's, disease X. Is there anything like that CMS is using?
It's something that I think we're starting to think about, but also, as Mona mentioned, the government has limited resources, and that's where I think putting our data out there, and whether it's sharing within HHS, so CDC, who's thinking about this very much more from a public health perspective, right? And how do we stop, public health epidemics? Or it's researchers at, academic institutions who are using the data to come up with those things and sharing them, whether it's through peer-reviewed journals or that sort of thing. I don't think it's something that we can do by ourselves. And that's where open data and kind of, whether it's sharing across HHS, sharing with researchers, doing what we can to make data publicly available where we can summarize it and aggregate it, and getting the entire community thinking about these things is really valuable.
I'd also say that to be, the AI part is actually easy. Really, that is not hard. It's just great algorithms and great models that kind of get you there. But to create the infrastructure that allows that to happen, that's really the tough part. And having data in ways that can be linked, in ways that are accessible and shareable and responsible ways, that piece is really, really tough. That's an unglamorous part of data that nobody wants to really spend enough time on, either in the public sector or, frankly, in the private sector. And I think the rest of it will be much easier. Again, I think the bulk of the focus right now for us is in creating that infrastructure that can enable that to happen long term.
I think that's the step in the right direction. I think it's University of California, Irvine. They have all these data sets, but it's in a format that everyone can kind of digest easily, right? And And so they provide these data sets. These are old data sets, and people use them to train, teach students how to do machine learning, right? But if you imagine if HHS and CMS put their data sets out there so that people can sort of look at it, understand it, right? And start thinking about how you combine that and put it out there, maybe offer up some Kaggle competitions to do things like that. I mean, I think there's so many people around the world and also in the US that can do the modeling side of it. But the data component, making it very accessible and usable and sort of understandable in a common framework, I think that's the difficulty. I agree with what Mona said. The AI machine learning is actually the fun, easier part. The real hard work is actually getting all these data sets and cleaned up and putting in a standard format and being able to allow researchers to link across data sets. So I built my whole career, basically my whole career, of just taking 2 data sets that nobody sort of linked together and just linking them and then doing some machine learning on top of that. And that's my whole career. So whether it's financial data and Twitter data or financial data and geolocation data, it's the combination of sort of different data sets is explosive. But the problem is, why do I get a career out of that? Is because it's really hard. Nobody wants to do it. They want to give me the data and then I'll build my machine learning algorithm in this data set. I don't want to link it across to something else, right? linking data sets is very, it's a lot of work, right? But the benefits there are tremendous. And
also,
so,
can I just say, to our earlier conversation, I think being able to ask the right questions. We don't spend enough time talking about the context and the right question, and your big data is only as good as your small data. Right? That's really, like, you have to get back to basics a little bit.
I also, sorry, just don't want to forget that we're dealing with a vulnerable population here, and privacy is an important thing for us to be thinking about. And so, while linking data and getting data out publicly is really important, and I think there's a lot of value to it, we also have to counterbalance that with making sure that we're protecting the privacy of our populations.
There's an example, one of my favorite examples of data sharing and value from it in the government is Federal Student Aid and IRS got together, and they had a really concrete user question, which is, what's the comparison in value between different universities? And the way they answered that was they said, anybody who's ever applied for federal student aid, we've got what date you started college, what date we presume you finished, and your social security number and your application. They went behind the scenes and said to the IRS, okay, for the people who graduated 10 years ago from University X, what is that person's current salary? And the IRS said, well, you know, it's private data, we can't share that with you. But the mashup happened between this, behind the scenes with the social security number, and then it was stripped away so that you had enough people from any given college, you know, if there were only 2 or 3, you just didn't do it, but so that at the end of the day, someone could understand, well, what is the earning of someone who's been finished with college for 10 years, only possible with government, because the government's the only folk who has this data, only possible because government was willing to share the information and match it using non-public information, and then strip it out. And I guess my question kind of is something like that possible in the health arena? Because I think what Jim described, let's get their genome, and let's get their opioid prescription. Genome information is confidential. The question is how
absolutely it's possible.
How to do that.
Yeah. So I'm going to just you know, tell you a little bit about what we've done so far at Grand Solutions and Dobell Technologies, and these guys are very, very innovative, and that's Michael Curtis and Doug Levy. So what we did is we have the ecosystem of data in Grand Solutions, so we have access to all this data, and we started to bring in outside data sources, as Jeff mentioned, from the IRS and so forth. And this is an explosive combination because we built a model that says we're going to predict if you, the grantee, has an audit issue in the next year. And how do we do that is we got internal buy-in, we have access to all the data, and we're allowed to bring in and augment outside data into our models. And you know, the models are around 95–96% accurate in terms of their prediction ability because of this combination of outside and internal data. So you know, half of the challenge is you got to find an ecosystem with people who are thought leaders who are going to allow you to do this with the data, right? And then you know, that is the difficult part, I think, because you know, a lot of organizations, you know, unfortunately, they won't allow you that much flexibility in terms of pulling data together, right? I don't know. I mean, I think that's where the opportunity is in government, to be honest, because there's frictions. I mean, there's tension why these data sets can't be combined. Okay, whatever they may be. Maybe it's privacy, maybe it's regulation, whatever it is, or maybe people are trying to sort of, you know, I call them data fiefdoms. They just are protecting their data because they think if they allow their data to be on a capital composition, they may lose their jobs or whatever. But there are these data fiefdoms across, you know, even the same organization, right? I mean, at Johns Hopkins, we have a lot of data fiefdoms. I'm like, can I use this data and this data? Oh, no, you can't look at student records. You can't look at admission records. I'm like, all right, fine. You know, I understand, you know, the tension here and what you're trying to do. But then that sort of holds back what interesting things you could do had you been able to combine these data sets. So my only sort of contribution to this panel discussion, besides stirring the pot a little bit, is that you know, we should have a conversation about how do we combine data sets, how do we make it easier. We have to understand that that's a big challenge and it's a big lift, but the benefits there are amazing. You can do really interesting things that will, you know, change the way that, you know, government behaves, and also allow people to do, you know, instead of doing the task over and over again, the stuff that, you know, would move up to the higher level tasks, right? Free up people working in the government's time to do more interesting work, you know. So.
And I think Mona is doing a lot of work to increase the amount of data sharing that we're already doing within HHS, but there are examples of where CMS is already doing this, whether it's internally with our own data, so linking the Medicare data with the Medicaid data for beneficiaries that are enrolled in both programs, the dual eligible population, right? Or it's working with the National Center for Health Statistics, who collects all of the death information from state coroner's offices, right? And linking that with the Medicare data to say, okay, you know, let's look at, we know fact of death in Medicare, right? Because we have to know someone's not eligible to receive benefits anymore for fraud purposes, but what NCHS has is cause of death. And so being able to take that information and tie it to the claims information, right, is a really valuable resource.
Mona,
I was just going to say, if you want to look at how you know, we've used data sort of across the federal government before, my previous team, the White House Social and Behavioral Sciences team, which was really, anybody familiar with nudge theory? A couple people. Economics people here? No? So nudge is really this idea of small behavioral changes, not just economic incentives, can lead to improvements and outcomes. And so the team really worked across the federal government to embed insights from behavioral economics into government programs. And then we ran randomized control trials of those government programs to see whether in the small subset that were impacted by our small nudges, were there changes in outcomes, both in effectiveness and efficiency. And so as part of that team, as part of that White House team, we worked across many different federal departments, including Department of Education, HHS, CMS, the VA, and it gave me a huge sort of context for how data sharing happens within the federal government or not, and the potential for being able to link those data sets to really achieve outcomes that we would all want to see. And again, you don't have to share any PII. There are absolutely ways out there that we can link information and not have PII available. And I think that gives us the intended aim of that data, which is to really help improve how programs run. There's a couple of questions.
My name is Swami Swaminathan. I'm from REI Grove, and we work a lot with the CMS especially. So a few months back, we started putting together a white paper. And it's all about outcome measures related to opioid. And during the process, we found some gaps in our own study. For example, opioid data is as good as the data that's collected, right? And we all know that there are many times there is opioid consumption happens outside our prescription. So my question is multifold. One is there anything that the government can facilitate or enforce across the broader spectrum of the healthcare organizations, especially providers? For example, if a senior citizen consumes opioid as a prescription medication, and the medicine sits in a cabinet, somebody comes to the house and they have access to the cabinet and they could potentially consume that too. And sometimes that could be lethal and they are taken to the hospital. And that data doesn't come to Medicare at all, right? So in order to do the comprehensive analytics, is there anything that can be done so we can look at everything together? Okay, fine, so-and-so is related to so-and-so, so-and-so has got some issues with opioid, came to the hospital, now we have the data. And the Medicare patient also has the prescription medication data. So we have to look at both. And I completely agree with you that it's not just the data alone. Sometimes you have to look at the whole picture to come up with more accurate analytics. Are there any initiatives, thoughts that's happening from the government side in order to have this ecosystem of healthcare organizations to partner and collaborate, and perhaps even make the data accessible to researchers and other people who want to do any kind of meaningful research?
So I think we have to just agree that we're never going to have the complete data set that we would want, and try to just leverage what we currently have and fill in the gaps that we think are essential. So there are data sets that look at, that have the poison hotline data, for instance. Then you have the 911 data, you have hospitalization data, you have claims data. There's a lot of data out there, actually. And I think the more critical piece is to be able to get access to timely data and data that's actionable. We can spend a lot of time trying to understand the problem and trying to address it on the back end. But how awesome would it be if we could have real-time data to the extent possible, so we could understand what is happening in a community or where hotspots are emerging that could get targeted. I think that's sort of where my mind is as a researcher. Yes, would I love to have the complete data set? Absolutely, but it's just not going to happen.
But actually, you bring up a good point about the other data sets that's available. CCW, which is the underlying warehouse on the VRDC. Can we have all those data be available in CCW as well?
You mean other data that's not CMS data?
Yeah, outside of Medicare and Medicaid.
So I think it's something where, CMS has the data that we collect for running our programs and we make that available. What we offer with the VRDC, right, is the opportunity for other folks to bring their data in and link it and do research. So, CMS isn't going to have the same data that a state would have or that, a nonprofit that does a survey might have, but enabling folks to bring that data in and do linkages, I think, allows for some of that research to happen. I think the other thing, just building on what Mona was saying, is I think sometimes, and we do this to some extent at CMS, right? We think, we have to gather all of the data and put it together and put it in a format that we can use it. And I think that's the wrong place to start. I think the place to start is what is the decision you're trying to make? Or what is the problem that you're trying to solve, right? And working backwards to say, I don't know if what you would do if you could say that, this individual overdosed because they took their Medicare beneficiaries, opioid prescriptions that had been in the cabinet for 3 years, right? So I think it's more thinking about what is the decision that you're trying to make, or what is the question that you're trying to answer, rather than just gathering up all the data and linking it together.
I think that's a great point. I mean, this only works if you have an outcome you're trying to improve and you're very focused on the question, on your hypothesis, and you test it with data, and you notice that you have to combine these different data sets. The other thing is also there are a lot of startups trying to solve this problem. It's not just the government. There are a lot of startups like BlockMedX that's trying to issue a token, it's trying to use the token, understand the front end where the pharmacist is giving the filling the prescriptions from the doctors and so forth. So there's a lot of really innovative companies that are trying to solve this problem. I think it's a combination of both. I don't think you can say government solve this problem, right? I think you incentivize startups to help solve this problem. So that, and then we do a lot of education, because I think, to be honest, if we're all fully educated about what sort of happened and what transpired to get us here, we could sort of encourage our colleagues to slow down the prescriptions, especially for young people who maybe break their legs because they have some soccer action or something like that. And then we sort of shift it, it's an education problem, it's a transparency problem, right? I mean, if we could be fully transparent to see who's giving the pills to whom all through the ecosystem, right, whether it's in a blockchain, I mean, we would be able to determine the bad actors. And we would be able to determine, whether it's this pharmacist or this doctor, or in this region, we're putting too many of these pills here, right? And so, is that available? Yes. Can we do it? Yes. Does it take some coordination and education, everyone? Yes. So I think the future, especially with big data and analytics and machine learning, is very bright, because this is now part of what we do every single day, right? This is not something sort of we have to go learn and do this stuff. It's already inside the things that we're doing in terms of our processes.
Jim, what I really like about that is kind of evidence-based best practices. In REI, with our HRSA client, we work with them to figure out which of the 1,000 clinics across the country are obtaining the best results on, for example, minimizing low birth weight babies or maximizing compliance with taking your high blood pressure medication, to try and figure out who's doing it best. But then I think it kind of slips over to what Mona's suggesting, which is, well, the data does one thing. Maybe it helps you figure out who's really good comparatively, the top 5 percentile. But then you have to figure out, well, how did they get to be good? And what I kind of wonder is, again, with the breadth and the huge amounts of data at CMS and of course some of the other HHS components such as CDC, you might be able to say, across the whole country, public and private sector, here's the community that's done the best in tamping down an opioid problem. And so my question is whether or not with opioids or other things, are we first using the data to find who's succeeding, and then second, going out to learn what are they doing differently? Is that happening kind of systematically?
It is to some extent, right? So our innovation center is focused on thinking about how we pay for value, right? Rather than paying for volume in the fee-for-service program in Medicare. And so one of the things that they're constantly thinking about and looking at data for is to figure out, well, CMS, the way we pay in fee-for-service is procedure by procedure, pill by pill. And so are there ways that we can, identify new ways to pay doctors, whether it's paying them, a bundled payment for a, post-acute coming out of a hip and knee replacement, right, and post-acute services, right, which impacts, opioid use because they may go back to the hospital if they take a whole bunch of opioids and end up, with some sort of adverse event. But starting to think about how do we incentivize, right? How do we just identify those, but how do we change the way that we pay for services to drive towards value in healthcare?
Mm-hmm.
I'm sorry, I need to stake out.
I understand.
Yeah.
Thank you so much.
Thank you.
Let me, if I may, Ms. Olschlager, ask a kind of a really specific follow-on question. If I and REI were to volunteer and come in and say, hey, we'd like to look through CMS data and find out where A, there have been the most hip replacements in the country with the lowest proportion of subsequent opioid prescriptions to those same patients. Now, presumably, of course, there needs to be a tie-up with the patient information, that's the private information between who got the hip replacement and who got the prescription. But if you could find, all across the country, the 10 communities out of thousands, hundreds of thousands, the 10 that did it best, that had the fewest opioid prescriptions per hip replacement or such, that might then give us a really interesting basis to go say, and how did they do it? Did they use alternative painkillers? Did they use a different prescribing technique? Did they have some sort of policy? Did they have some sort of motivation or incentive, or was it fiscal or was it educational? And so I guess my question is, if a private company like REI volunteered to come in and try and do that, would we be able to? Would we be permitted?
Yes. So with our virtual research data center, we have the opportunity for anyone to come in and do research. The issue is you're accessing personally identifiable information, right? Yeah. And so CMS doesn't receive appropriation dollars to make our data available for research. So we do charge the cost of making the data available and expect researchers to sign a data use agreement. You would work within our environment, right? So we can audit what you're doing and make sure that you're not inappropriately using the data, right? You can only take out summarized information, so you can't take out any beneficiary information about, Medicare beneficiary A had these prescriptions, right? But you could take out summarized information to say, in this county, right, I'm seeing high rates, or for this this practice that has 100 beneficiaries, right? What are the results I'm seeing? And so we do allow that. If you're interested in that, the place to start is our Research Data Assistance Center, RESDAC. It's www.resdac.org. And they have a whole bunch of information on their website about the process for requesting data, fees, the data use agreement, what we expect in terms of, we do expect you to be doing research, right? So coming in with a research protocol, having gone to an IRB and say, is this research actually, is it a good research protocol, and is it not going to harm the Medicare beneficiaries? But it's something that we do allow folks to do.
And if I bring along my good friend Jim, who's got this software tool that he created and it's bundled together with some other tool like SAS or SPSS, would Jim's software tool be allowed to operate on the data sets that you have?
It depends on the software tool, right? So we have to evaluate it to make sure that you're not bringing something into our environment that's going to, corrupt it or anything like that, right? And we do, again, we're charging the cost of making the data available. So if it costs us money to load, Jim's tool, then we're going to charge you that cost. But it is something that we allow researchers to do.
So what about if you anonymize the data? Can you provide that into the public domain?
We've done a lot to
Okay.
put data out publicly to the
Yes.
extent that we can, and are constantly working to make more data publicly available. Like I was talking about earlier, we have a public use file that has over 1 million records. Every single prescription that a prescriber has prescribed and a Medicare beneficiary has filled is publicly available as long as, you know, the prescriber has done at least 10 prescriptions, right? Because we don't want to get back to the individual beneficiary's information.
So this is so interesting, and this is one of the things that I'm trying to sort of understand more. So you have this data set of, you know, patients, right? And it's all anonymized. And then you have another data set that's probably pretty interesting that you could try to combine. But since this is anonymized and this is anonymized, you can't really combine them anymore because you don't know, right? So I wonder if there's a way to like combine the data sets internally and then anonymize it and then provide it to the public. So now we can sort of have a rich feature space in order to create our models and so forth, right? I don't know.
Yeah, I mean, I think there's always opportunities
Yeah.
to combine data and do what we can to make it publicly available. Again, it's just a question of resources, right? And how much time do we spend analyzing data? How much time do we spend making our data publicly available? And how much time do we spend, you know, figuring out how we make data available to researchers?
So there are a lot of research conducted today at VRDC.
Mm-hmm.
So is there a catalog of all the research so we don't have to duplicate the effort that's done by somebody else? So can we know the outcome or the process that they went through, the data set that they used? I mean, is there somewhere there to get all this information?
It's not something that we make publicly available right now, but I think there's a lot of research out there. So people are publishing their research consistently in journals or white papers or that sort of thing. So I would say, you know, that's a good place to start, is looking at the academic literature and seeing what's already been done. But I also think there's opportunities to take studies in a different direction than someone else may have done, right? Or think about a problem from a different perspective. And so that's why we're always encouraging researchers to come in and use our data in, you know, new ways.
So I'm going to ask some questions because I'm a professor here. How many students are in the audience? Okay, good. And then how many people in the federal space working for the government? Okay, and then how many people are like, you know, pitching to the government? So I don't know what it's called. Okay, good. Okay, good. And then how many people can do machine learning and AI? That's very good. Okay, interesting. I'm just, you know, curious to get a sense of the audience.
I think, was there a question in the back?
Yeah, if you don't mind. So we are working, our team works in the behavioral data analytics space, so combining the two in order to basically make predictions based on data and behavioral models that we combine or whatever. One of the things, though, that I find interesting is that there is a lot of tools and data available to make a lot of decisions on things, but we're finding that decision makers are skeptical sometimes of using predictive analytics to make decisions, whether it's resources or policy. Just want to get your impression on whether or not you see that changing over time and whether or not you see people using those, truly using predictive analytics to make policy decisions, to make resource decisions down the road. Because right now, you know, there's a little bit of uncertainty around using that for those big decisions.
I can only speak to my experience at CMS, but I have constantly seen across our leadership team an interest in using data to make decisions. I think, you know, there's always a question of how are you doing that analysis and kind of what data are you using, and explain to me how you're getting to this result. But it's exciting from my perspective to see this big interest in having data drive decision making.
So, I mean, I'll just comment a little bit from the business side. You know, at the end of the day, you have to convince something, you know, to do something, right? And usually there's a picture. And the picture is like, you know, one axis is good and this axis is also good, so you want to be over here, right? And so you can put data points and you can say, okay, you know, you ran all your machine learning algorithms and you did all the quantitative work, but you summarize everything into like a simple graph, and you say, okay, if we do the machine learning and we do all this, then we're going to be here. versus if we don't do anything, we're going to be here. You guys make the decision, right? And so I think it has to distill down to something very simple like that, right? I mean, I like to use that example and also the doors, right? Here's door A and here's door B. Door A, you do exactly what you're doing right now. But if you go through door B, you get a 10-time multiplier on your revenues, or maybe you reduce expenses, or you reduce the time frame, right? These are the two doors. Which one do we want to choose? It's like a no-brainer. I want to go through door B. And then you say, okay, well, if you open door B, you got to do this machine learning and you got to do this blockchain. So are you willing to do that? And most of the times, you know, people will say, yeah, of course, because it's such a big bang for the effort that we're going to put in, right? So you got to make it very compelling, and you got to give, you know, decision makers a decision, but it's got to be kind of an easy decision, right? It can't be, you know, should we use support vector machines, or should we use random forest, or should we use auto machine learning? I mean, then they're like, I don't, you know, their eyes glaze over and they don't know what's going on, and you know, and then you start try to throw out some confusion matrices and rock curves, and then they're like, we're gonna have another meeting, right? So you know, you have to be strategic how who your audience is, and you can absolutely affect change with data.
I can go one step further.
Yes.
One of the things that we're looking at is, you know, can we make predictions on where the opioid crisis is headed based on behavioral and data that's around that, and then maybe reverse the wrong word, but shift resources to that area, even though maybe today it doesn't look like a problem space, but tomorrow it very well could be based on the, you know, predictive analytics that we're doing. And the concern is, well, the problem, the hot spots here today, and that's where the resources are going, that's where the focus is going. And to shift that focus elsewhere gets people nervous, right? Because but we're, you know, through the analytics that we're doing, we're trying to say, well, here's potential next problems. So let's try to get ahead of it here, as well as trying to recover it from here. So that's why I asked the question.
Yeah, and I think, you know, a really good point is when you're doing this data analysis work, ultimately the goal, right, is to translate it to policy decision makers. And so it's important, particularly for the students in the room, to think about not only can I do the analysis, can I do the machine learning, or do I have the coding expertise to manipulate the data and come up with some result, but also how do I present that information? And it's something that I'm constantly working with my team on, because we're presenting our data to, you know, the administrator who only has 5 minutes to think about this issue because she has 100 other issues that she's thinking about that day. And so how do we communicate that in a way that she can easily understand and quickly, you know, get to the decision, rather than understanding, you know, okay, I have this really complex table, it has 500 variables in it, let me walk you through that, right? Some sort of visualization or some sort of very basic table with, you know, 4 or 5 data elements.
See, so Allison has a very sophisticated, even though she's, you know, young, she's very sophisticated because she knows how to effect change using all this high-powered technology, and she understands the audience that she's presenting to, right? So, like a lot of times I teach big data machine learning, and the students get so excited about the technical details, they can't present what they found in a way that's digestible to the audience, right? So they fail on the communication component, and then that happens a lot with data scientists. I mean, so, you know, I mean, I suspect, you know, why Allison is going to have such a wonderful future in this field is because she can talk to the data scientists and the engineers, and then she can communicate effectively to the decision makers, right? And so that is a very important skill. It's a kind of a rare skill if you think about it. So, you know, that's why you'll be in the White House pretty soon, right?
Allison and Jim, may I ask, my wife works with the President's Emergency Program for AIDS Relief as part of USAID. AIDS has been a big health crisis, kind of continues to be, and bluntly, as I have conversations with her, she and her team have learned a lot from a bunch of other countries. And so that makes me wonder whether or not, are we learning as a government, are we learning as a community about opioids from addiction problems in other countries, perhaps opioid addictions, and are we finding, for example, analytic models or kind of structures of data that from those countries that might be interesting to us? And if so, can you share any such kind of learnings?
That's not something that my team has looked at extensively. I know there's research and I've read numerous articles about this, but it's not something that we're currently working on.
Okay. I mean, I think other countries have similar problems. Some of them don't, because the policy is that, you know, they have a zero tolerance to drugs and so forth, right? But, you know, I think it's a global issue, and you know, it's not easy to solve because, like you see, if I'm a doctor and I see someone in pain, I want to try to reduce the pain, and you know, what are my levers I can do, right? And so, you know, I can give them aspirin, maybe that's not enough, maybe I have to give them something a little bit more, right? So there's a whole spectrum of things that I could try to help the patient. So I can understand the motivation of trying to solve the pain problem, you know, but the issue, I think, it is fundamentally, it was misrepresentative how addictive these pills could be. Okay, and so that, yeah.
Regarding that question, NIDA, National Institute on Drug Abuse, they have a huge international program, and Dr. Nora Volkov, who is the head of the NIDA, she is very much in touch with international community with regard to the disease of addiction.
And I think that's a great example, right, of where NIDA is part of NIH, right? So they're doing the evidence generation, the research in this space, and then sharing that information with CMS, so that information can, that information can be used to help the decisions that we're making in terms of how we're paying for services.
And also SAMHSA. By the way, we shouldn't exclude SAMHSA.
Yeah.
Does anyone know other countries that have a significant sort of opioid problem, more so than America?
Iran.
Iran? Any
China.
other countries?
Brazil.
I don't know if China has an opioid problem. Maybe the Philippines, I'm not sure. So this is a global sort of problem that we're dealing with.
I wanted to really reiterate Dr. Siddiqui's point about that not everything is a data problem, and we really need to keep that in mind. It's very easy to just say this population, this physician, is prescribing opiates or whatever, and I think, Allison, you had mentioned that patient goes to the hospital, gets oxycodone or a narcotic script for orthopedic surgery, for knee surgery, and then comes back with an addiction. But more times, what happens is the patient goes home without any pain medications and comes back. Now, pain medications initially after the surgery, say for instance, if you compare India, I know India very well, my family's there, so if you compare India with the United States, it's 1 billion people. We're like, what, 200 million? So India's a lot larger, but there are hardly any opiates in India. However, an 85-year-old in America with 3 back fusions and a cervical fusion and 2 knee replacements is active. Someone like that in India is not active. They die from pain. Like, I have seen it because, I've had family members in India and the doctor needs to give you they won't do it. So the rib fracture, sitting in bed, what does that lead to? That leads to bed sores. That leads to immobility. That patient's done forever. Whereas in the United States, if you do it properly, that same person, because of pain medications, is allowed to walk that day with physical therapy, is allowed to go home, walk upstairs and get the right resources. So there's a big balance, and I think we tend to look at all the bad patients, but opiates are needed in certain circumstances, and that is why an 85-year-old in this country can actually be a Supreme Court justice, and an 85-year-old in India or China or any of the Asian countries, even Mexico, cannot. And that's what we need to keep in mind.
Yeah, I think it's a really good point about appropriate prescribing habits. I think another thing that we're thinking about at CMS, right, is are there alternative pain treatments, right, that, may be as effective as opioids at reducing pain, but don't have the same risk of addiction. And so it's, it's finding that balance.
Is there any?
Yeah, so another thing to consider in this, though, especially from CMS, and it came out through the Comprehensive Addiction and Recovery Act as well, unintended consequences of public policy. So CARA had said that opioid prescribers within VA have to decrease the numbers of opioids they prescribe by 30 to 40% over the next 2 years. That was ending in 2018. They did it. The proportion of veterans who die of an overdose increased by 5% during that same period, which now shifted to synthetic opioids, which were purchased outside of the VA system illegally. So now the VA is starting to reconsider, how do we focus now on the synthetic illegal opioids that people have been obtaining because they can no longer get opioids from their clinicians. So we've really got to start being thoughtful, and this goes to your point about using data across different areas, comparing FBI arrest records with opioid hotspots, with people that are the different dual eligibles. When you think in terms of dual eligible, you think of Medicare and Medicaid. But what about Medicare and VA? What about TRICARE and Medicaid, TRICARE and CHIP? These are all dual eligibles too, with data sets that don't share data in any way, shape, or form. And when we start looking at those types of dual eligibles, when we start considering what can happen, I'm an evaluation scientist, so I'm constantly focused on what can happen wrong, and how can we back into doing that properly by using something called a logic model and thinking sensibly about the influence the impact ultimately has on the inputs. But one of the things that I would encourage you to do in the development of data-related public policy is to think about what it is we're suggesting, especially when it comes to physician incentives, that might go horribly wrong.
Yeah, I think it's a really good point. So a couple of thoughts. The first is that we actually do share data with the VA. So not only are we doing Medicare, Medicaid dual, but sharing data, Medicare data with the VA to help them understand how, you know, Medicare prescribing habits align with what's happening out of the VA. I think the other thing that we haven't talked a lot about, we've talked a lot about how do you predict, how do you figure out that a crisis is happening, but I think there's also how do you monitor what is happening as you make policy decisions to evaluate if the policy decision you've made is having the intended effect, right? So that's also something that we're doing at CMS is using data to make decisions, but also using data to continue to watch what's happening as a policy decision gets implemented to make sure that it's having the intended effect, right? Because what we don't want to do is, you know, have unintended consequences that result in something, you know, where a beneficiary is having really severe pain and they can't get the treatments they need, or you know, there's another crisis because of some policy decision. So it's also about monitoring and kind of evaluating constantly the decisions that you're making and keeping track of if they're having the intended effects.
And two other really important areas to think about. Number one predictor of opioid overprescribing is antibiotic overprescribing among physicians. If you have a physician that's overprescribing antibiotics, look for opioids. And the other is an area that's outside of your purview in CMS, is the dental prescribers. The prediction of opioid abuse from dental introduction of opioids is significantly overrepresented compared to physician introduction. Points of interest.
All right, I think we are at time. So we are very grateful to our panelists. We'll give them a round of applause. Thank you. Our next Government Analytics Breakfast Forum will be in February, so please keep an eye out for it. You'll probably receive an email, and it'll also be posted on both the REI and Johns Hopkins website. So we hopefully look forward to seeing you back here in February. Thank you.